Our favorite topic, right? This is the other title of this talk, right? So, what we're going to do is talk about some definitions related to nystagmus. We're going to review the eye movement systems, which I don't know that you have to know so much for your clinical work, but they might put it on tests. So it's a basic anatomy and physiology of the eye movement systems. We'll talk about some features of the history you take in patients with nystagmus and the exam. Try to distinguish peripheral patterns from central patterns of nystagmus. A little bit about positional vertigo and distinguishing central from peripheral. We're not going to talk about infantile or congenital nystagmus today, just because we don't have that much time. And we'll talk about the localizing central forms of nystagmus. There are also saccadic oscillations like opsoclonus we won't go over today, but we'll do when we do a supranuclear another time. So, nystagmus is defined as a rhythmic, repetitive oscillation of the eyes, and it could be physiologic or it could be pathologic. So, it's physiologic in response to environmental stimuli, being rotated or moved, or going out into outer space, for instance, or in change in body position. Pathologic due to neurologic brain disease, but also one of the big things that cause nystagmus acutely is peripheral vestibular disease. And finally, visual loss. Associated with visual loss, particularly in infants, you'll get nystagmus. When we define symmetry, we say it's either conjugate if both eyes are doing exactly the same kinds of movements, disconjugate if one eye is moving in a different way than the other, dissociated if they're going in opposite directions, or totally dissociated and asymmetric, and that would be monocular. By convention, we call the direction of the nystagmus the fast phase, even though the problem is the slow phase. The fast phase is a correction that the brain does, but we define it, if it's fast to the right, it's right beating. So here's, let's say this is a vertical tracing. You see that there's slow up, fast down, okay? And so that would be downbeating nystagmus. So it's left, right, up, or down. It could be rotary or torsional without any actual movement of the eye except to rotate, and that could be clockwise, counterclockwise, or we may say it beats towards the right or towards the left shoulder, which takes away the ambiguity of clockwise, because we don't know if you're talking about the patient or the examiner, right? So we say it beats to the patient's right shoulder, we know it's going that way. Now, sometimes confused with clockwise is circular, elliptical, oblique, but this is where the actual combination of vertical and horizontal are. So it's not just rotating, it's moving in a circle or an ellipse or oblique when there's a combination of vertical and horizontal nystagmus. We define it, the waveform, as either jerk or pendular or a combination thereof. So jerk has a slow phase and a fast phase, hence the jerk, and pendular has just slow phases. So it's equal in both directions that it's moving without a fast phase. And sometimes there's a combination, particularly in infantile nystagmus, is a combination of fast and slow phase. So the problem is a defect in one of the slow eye movement systems, such as the vestibular, pursuit, optokinetic, or neural integrator. So the eyes drift slowly in one direction, and then the saccades come in, the brain comes in and says, hey, the world moved, I didn't move it, let's correct that. So it drifts slowly, it corrects it. Drifts slowly, corrects it. And so that's why we get the jerk nystagmus. So it's a defect in a slow eye movement system, and we have these 6 slow eye movement systems. We have fixation. If you want to look at an object, you've got to be able to keep your eyes steady. We have the vestibulo-ocular reflex for movements, to be able to keep your eye where you want it when your body moves. We have the optokinetic, we have the neural integrator, we have smooth pursuit, and we have vergence, both convergence and divergence. And why do we have eye movements? Same reason as last year, right? To maintain the images steady on the retina in order to preserve visual acuity. So our central acuity is, say, 20/20, 20/15. If you just go a few degrees off, it really degrades rapidly. If you're fixating on something off to the side, your acuity is quite bad. So we need to keep our fovea on where we want to look. So even tiny movements of images on the retina, 2 to 3 degrees per second would degrade our visual acuity. So that walking, when we go up and down, or even our heartbeat, would cause blurring if we didn't have these corrective eye movements. So our slow eye movements maintain steady fixation or follow moving objects. And the systems that hold eyes steady are the fixation, vestibular, optokinetic, and neural integrator. And we'll go over those. So visual fixation allows the images to remain stationary on the fovea when the head is stationary. So we're just looking at something, we want to keep looking at it, you don't want it to drift off. And this begins in the occipital lobe, which still makes sense. The vestibular system allows images to remain steady on the fovea with brief head rotations. So the head moves, but you want to fixate, so you just stay where you want. And this begins in the semicircular canals, goes in the brain via the vestibular nuclei to the oculomotor nuclei. So it goes through the 8th nerve to the 3rd, 4th, and 6th. The otolith ocular reflex responds to linear head acceleration and lateral head tilt. Now let's say we maintain our head rotation, we keep rotating our head. Then the vestibular system gets saturated, and we need another system, and the optokinetic system comes in. And this responds to head rotation beyond vestibular, and it responds to a visual optokinetic stimulus, and it takes over for the diminishing vestibular labyrinthine signal. Let's say we want to keep our eyes to the right to look at something. We have what's called the neural integrator, and it maintains the eccentric position of the eyes, overcomes the viscoelastic forces of the orbit that would tend to bring the eye back to the center. The reason it's called an integrator is because it's a mathematical integration, which integrates the position command from the velocity command to produce appropriate neural discharge. So to get the eye from the center to the side, there's a velocity command, and the integral of that is what the brain needs to do in order to keep the eye there. The horizontal neural integrator is the medial vestibular nucleus and the nucleus prepositus hypoglossi. The vertical neural integrator for up and down movement is the interstitial nucleus of Cajal. And the cerebellum, particularly the flocculus and nodulus, play an important role in the neural integrator as well. We also have systems to fixate moving targets. If let's say our head's stationary, but the target is moving. And so we have smooth pursuit, which follows a moving target up to 40 degrees per second. And so you see the tracing of a slow movement right and left. It's ipsilaterally controlled, so it comes from the ipsilateral temporoparietal occipital junction. So if you have a lesion on the right side of the brain, you'll have poor smooth pursuit looking to the right. And so looking to the right, you might see saccades, rapid eye movements, replacing pursuit. There is some input from the frontal eye field and the supplementary eye field, which is even anterior to the frontal eye field. Similarly, if something's moving towards you or away from you, we have to use convergence or divergence to keep the image focused as the object moves closer or further away. And the pathway here is the occipital to the midbrain for convergence and to the pons for divergence. So can we tell when we have a nystagmus patient which system is faulty? You sort of have an idea if you did a tracing of it. You can't really tell looking clinically, but if you did a tracing, you'd see different velocities. So let's say it's linear, like, let's see which one. This one right here. It's a steady velocity. That would be a vestibular abnormality, either peripheral or central. If it was decreasing, so that as time goes on, the velocity decreases, you see how it comes up there and then fades, and then you get the correction. That's the neural integrator. Okay? If it's increasing velocity like that, that's a defect in the smooth pursuit system, and we see that in congenital nystagmus or infantile nystagmus. So those are the slow eye movement systems. We're not going to talk about saccadic oscillations today, but we'll talk about the basics of the saccadic system. This is a system that moves the eyes rapidly to focus on something out to the side or away from center. And it resets the eyes during rotation, producing physiologic nystagmus, as well as resets the eyes during pathologic nystagmus, responsible for the quick phase. So here's a tracing of normal saccades, right and then left. And the control of saccades is many places in the brain. The frontal eye fields, supplementary eye fields, dorsolateral prefrontal cortex, parietal eye fields, superior colliculus, the PPRF, which is the paramedian pontine reticular formation, and the RIMLF, the rostral interstitial nucleus of the medial longitudinal fasciculus. So PPRF for horizontal, RIMLF for vertical. And then there are neurons scattered through the brainstem that dampen or prevent saccades, called the omnipause neurons. What if things go wrong? To overcome defects as well as changes in the environment, the cerebellum comes in to modify the system and dampen some of the activity. The vestibular cerebellum for pursuit, vestibulocular reflex and gaze holding, and the dorsal vermis and fastigial nucleus for saccadum pursuit accuracy. So, now we have a quiz on that stuff, okay? I'm glad we're done with that. What about history in these patients? So if someone comes in with nystagmus, most often they have no symptoms. So you ask them about symptoms, they have none. You just happen to see it on exam. But they may have oscillopsia. They may have a sense of shaking of the environment, and they may have decreased visual acuity if the movements are rapid enough. You want to ask about medications because probably the most common cause of nystagmus is a medication-induced nystagmus, such as anticonvulsants, sedatives, lithium, etc. You want to ask about alcohol or other drugs because that can cause nystagmus. We sometimes see patients coming in for their 8 a.m. appointment and they're a little bit drunk and they have nystagmus. Family history, you want to know if they have a family history of ataxia or other neurodegenerative disorders that will give them nystagmus. If they have central nystagmus, they may have other symptoms, so long track symptoms such as numbness on one side of the body, weakness on one side of the body, ataxia. Or they may have cranial nerve symptoms, so they may have diplopia from a sixth, or they may have a facial palsy or something else. Now, one of the things we commonly see is an acute onset of vertigo due to, say, labyrinthitis, right? So not so much the ophthalmology residents, but the neurology residents are called to the ER constantly with a patient with acute onset vertigo. And typically with a peripheral vestibular acute abnormality, you get vertigo, you can have hearing loss, you can have tinnitus, particularly with things like Meniere's disease, nausea, and vomiting. And on exam, when you see these patients, you want to first determine if the nystagmus is a unilateral peripheral problem or is it a central. And you do that by looking at the pattern. Is it jerk, pendular, what direction it is there a null point, etc. You want to do a head thrust test. So head thrust test is you take the head, you make sure they don't have a neck arthritic problem that's bad, right? And you move it back and forth, and you occasionally thrust it. And you have them fixate on a target, and you see if the eye immediately comes to that target, or do they have a corrective saccade. If they have a corrective saccade, then their vestibulo-ocular reflex is faulty. And if it's in one direction, that's a peripheral vestibular problem. So that's one of the criteria that neurologists now use, or ER docs use, to distinguish a peripheral from a central acute vestibular problem. If it's central, you want to localize it by looking at the pattern. Is there a localizing pattern? You want to look for a long-standing head turn or head tilt, which might suggest infantile nystagmus or spasmus nutans. And of course, you want to assess afferent visual function in these patients. So we look at them in all positions of gaze. We describe in each position as a jerk or pendular. We define the fast phase direction, the amplitude and frequency. Is it rapid and small, or is it slow and large amplitude? We want to see if there's a null point. And we want to examine them for a few minutes, because if they have periodic alternating nystagmus, it's going to switch direction. So once you do these things, you can really sort out what kind of nystagmus you have. Fortunately, I think most people see someone with nystagmus and they just call and say, hey, patient has nystagmus. They're afraid to look at the details because they know something's wrong and it can't be great, right? So what are the typical patterns? If you have a unilateral peripheral nystagmus, it's going to be either horizontal or horizontal with a torsional component. It's not going to have a vertical component except for BPPV, benign positional vertigo. But if you have a peripheral unilateral vertigo, someone comes in, sudden onset of a vestibular problem, it's going to be horizontal or horizontal torsional. It's going to be unidirectional. So if it beats to the left, it's going to stay to the left, even in primary gaze. And if it's still there in right gaze, it'll still beat to the left. It will not turn and beat to the right. And it's always a jerk nystagmus. It's never pendular. Central, on the other hand, the horizontal direction typically changes right and right gaze, left and left gaze. It may be vertical or pure torsional. If you have a pure torsional nystagmus, that's also central, if there's no horizontal component. It could be jerk or pendular, and it can mimic a peripheral pattern sometimes. And one of the reasons for that is that there's a artery off the basilar artery that goes to the peripheral labyrinthine. It's called the labyrinthine artery. And so you could have a central nervous system vascular problem that looks peripheral. You could also occasionally just involve the vestibular nuclei, and it can look peripheral. You want to look for associated findings, are there head turns or head oscillations to suggest an infantile nystagmus. All right. Now, if you have a peripheral vestibular nystagmus, it's often suppressed by fixation. So patients come in the ER, they've got vertigo, you open their eyes, you don't see nystagmus. And so they'll say, well, maybe it's non-organic, maybe it's functional. Well, you've got to be able to elicit the nystagmus. One of the ways to do it is you occlude one eye. You're in a dark room. You look with your direct ophthalmoscope in the other eye, so you're looking at the optic disc. And because you've blocked fixation, they can't really fixate. And so you elicit the nystagmus. And you see it by looking at the optic disc shaking. You'll see the disc shaking. And if it shakes to the right, it's a left-beating nystagmus. If it jerks to the left, it's a right-beating nystagmus, because you're looking at the back of the globe, right? You could also use Frenzel goggles, which are these goggles that have a very high plus lens, like a 20 diopter. And so the patients can't really fixate, and you can look at them in the light and see nystagmus come out. So we have a pair of these at the office. If you have a history of positional vertigo, you want to do the Dix-Hallpike maneuver, okay? And the Dix-Hallpike maneuver is you turn the head to the side, and you rapidly have them lie back with their head hanging over the edge of the table. And you look for positional nystagmus. Peripheral vestibular lesions include labyrinthitis or vestibular neuronitis, really the same thing, probably a viral disease. Meniere's disease, or ischemia to the internal auditory artery. Now, so with a unilateral peripheral vestibular lesion, you'll get a rotary or pure horizontal nystagmus, which does not reverse direction. It's worse when you look to the fast phase. So if it's left beating, it'll be worse in left gaze, so-called Alexander's law. And the fast phase is away from the destructive lesion. So if you have an acute labyrinthitis on the left, the nystagmus will be to the right. And you tend to fall towards the side of the lesion. So if we have a diagram here, we have a damaged left labyrinth, okay? And so what would happen is the horizontal semicircular canal on the other side will move the eye slowly towards the damaged side. So there'll be a slow component towards the damaged side, and rapid saccadic correction to the good side. So left ear is damaged, beats to the right. So here's a 40-year-old man, sudden onset vertigo and nausea, and we'll see some peripheral vestibular nystagmus, only with the Frenzel goggles, right? So we have left beating nystagmus. It's really purely horizontal in this case. Doesn't beat to the right at all. Go to the left, it's worse. Take off the goggles and it's gone. You recognize that guy? My previous life. 25 years ago. That was not a labyrinthitis, that was ice water in my ear. Okay? So ice water in the right ear. It shuts down the response from there, and so it mimics a labyrinthitis. Benign paroxysmal positional vertigo is a brief vertigo. So patients will come to the ER and they'll have vertigo acute onset, and people will do the Dix-Hallpike maneuver. You don't have to do it. It's only if it's brief episodes of vertigo. They last less than 30 seconds, and it's introduced by change in head position. And one of the typical histories you'll get is you get rolling over in bed causes it to happen, right? Bending, looking up. And it could be due to head trauma, commonly after head trauma. It could be after a labyrinthitis, after a viral infection. And it could be idiopathic, right? And the pathogenesis is either canalolithiasis or cupulolithiasis. It's these little particles that move and stimulate the posterior semicircular canal. And if you have this, let's say you have it in the right ear, and you do a Dix-Hallpike and tilt the patient back towards the right, you'll get a counterclockwise nystagmus in the right eye, and a counterclockwise plus upbeat in the left eye. So here's the one exception where a peripheral nystagmus can have a vertical component. You can also have central positional vertigo, but that's quite rare. So the features that can distinguish on a Dix-Hallpike maneuver the central from peripheral are there's a latency with peripheral. It could be only 2 seconds. It could be rapid, but it doesn't happen immediately. With central, it's just right there. You move them down, it's already there. The duration is brief with peripheral, less than a minute, usually just 5 or 10 seconds. With central, it just persists more than a minute. Fatigability. If you repeat the maneuver right away with a peripheral vestibular nystagmus from BPPV, it will decrease. You do it a third time, it's gone. With central, it just persists. And if you come back to the upright position, it reverses direction if it's peripheral. So the upbeating eye will now beat down, etc. The central will not reverse direction. Practically speaking, for every one central positional vertigo patient, you might see there could be probably 50 peripheral. So here's a patient of Dr. Z's, and he was kind enough to share it. A Dix-Hallpike maneuver to the right with a patient with right benign paroxysmal positional vertigo, and you'll see, basically it'll focus on the left eye, and you'll see the nystagmus. That will be both torsional and upbeat. And having Frenzel goggles allows you to see it better. It magnifies the view, and so it's torsional and upbeat. The other eye will be just torsional. And it just lasts a short period of time, and then dampens. So that's a typical benign paroxysmal positional vertigo. It's important to make this diagnosis because patients can go on for years with symptoms, but if you know how to do the canal repositioning maneuver, where you actually start with the Dix-Hallpike maneuver, and then you move the head various positions as seen here. You can actually move those crystals from the posterior semicircular canal, and they get out and they don't come back in, and you cure the condition. So if you have anyone with benign paroxysmal positional vertigo, and you don't know how to do this maneuver, you find out who you work with, whether it be neuro-ophthalmology or if it's ENT or physical therapy, that knows how to do it and cure people. Here we have a patient of Matt Thurtell's with right beating nystagmus in right gaze, left in left gaze, right? But if you move back a little bit, and you don't see that here, it goes away. And so this is physiologic nystagmus. It's gaze-evoked endpoint nystagmus that's unsustained, and it's low in amplitude, and it's symmetric. And it fatigues after you stay in the lateral position for a little while. And if you move back to three-quarter gaze, it's gone. However, there's also pathologic gaze-evoked nystagmus, which most commonly is due to medications, as we talked about, or alcohol, but also structural lesions in the brain. So we're going to talk now about central nystagmus, and we're going to separate them into jerk nystagmus and pendular, and we're going to try to see are any of these localizing to different parts of the brain. So these are the localizing types: Bruns, rebound, INO, periodic alternating, downbeat, and upbeat. So we'll start with a 35-year-old man with progressive hearing loss in the left ear and dizziness. Okay? So we're worried about something on the left side, right? And he has this very large acoustic neuroma that is not only growing out of the peripheral nerve, but compressing the brainstem on that side. And it compresses the neural integrator. So what we're going to do is get a peripheral nystagmus because of this lesion, but a central nystagmus on this side because of compression. And so this is seen, it's called Bruns nystagmus. It's seen with large cerebellopontine angle tumors. There's a contralateral, high-frequency, low-amplitude nystagmus due to the peripheral vestibular component when looking the other direction. If we're looking towards the lesion, there's an ipsilateral, low-frequency, high-amplitude nystagmus due to compression of the neural integrator. And so we'll see a case of this. So what you're looking for is just an asymmetry right to left. And this and some of the other videos I'll show you are from the Neuro-Ophthalmologic Visual Education Library, NOVEL, which is a free site with tons of videos and lectures and slides of all kinds of neuro-ophthalmologic conditions that you can download for yourself or for teaching. So here's a patient with Bruns nystagmus, and you'll see the asymmetry. So there's a rapid low amplitude to the right, and we're going to see a larger, slower to the left. So you see it's a very asymmetric kind of nystagmus. And so that's Bruns nystagmus, CP angle tumor. See, very different side to side. Rebound nystagmus is a sign of cerebellar disease. Okay? So initially, looking straight ahead, you see no nystagmus. You go to lateral gaze, you see nystagmus. You come back to the center, now you see nystagmus in the center in the opposite direction of what there was laterally. So you come from the right, it beats to the left. You come from the left, it beats to the right. And this is a sign of cerebellar system disease. So here we'll see a patient who does not have nystagmus in primary position initially. You go to the right, and you have right beating nystagmus. Come back to the center, it beats to the left. Go to the left, there's left beating nystagmus. What do you think is going to happen when we come back to the center? Beats to the right, right? It goes to the opposite of whatever you had at lateral gaze. So it's always pathological, and it's a sign of cerebellar disease. Dissociated nystagmus is pretty simple. You see it in all your INO patients. You have an adducting deficit in one eye. Here's a lesion right at the INO in the pons. I'm at the MLF, I mean. You have nystagmus in the abducting eye only, which may reflect an adaptive mechanism to overcome the contralateral adduction weakness. So here's a patient I'm going to show you from the novel website, patient of Shirley Ray's from Boston, who has a bilateral INO. And so that's a monocular nystagmus in right gaze, because left adduction deficit, and a monocular nystagmus in the left eye because of the right adduction deficit. And typically this bilateral INO will be a patient with MS, right? So that's our main unilateral monocular nystagmus. Of course, in infants or children, spasmus nutans would be one that could be very asymmetric and be monocular. Periodic alternating nystagmus refers to, in primary position, a jerk nystagmus that goes one direction, slows down, stops, and then goes in the other direction, usually every 90 seconds. In lateral gaze, it beats to the side of the gaze. So in right gaze, you get a right beating nystagmus. In left, Chris Whiting wants to discuss a case. Anybody interested? All right. I guess we didn't finish training him. So there's right beating in right gaze, left beating in left gaze all the time. But in primary, it changes direction every 90 seconds. And it's due to a shifting null point. So on some points, you're on the right side of the null point, you beat to one side. Other side, you're on the left side of the null point. It may lead to periodic head turns, because as the patient's null point changes, he or she can move their head to dampen the nystagmus. And it's localizing to the cervical-medullary junction, as does downbeat nystagmus, or the cerebellum. And it could be congenital. And the importance of picking up congenital PAN is that the surgery, if you ever do it for nystagmus, is different for PAN than it is for the typical congenital nystagmus. You see it with arnold Chiari malformations typically, MS, infection, tumor, cerebellar degenerations, rarely with visual loss or toxic. And so you see the tracing of it beating one way and then changing and beating the other way. And so I'll show you a woman who has an arnold Chiari malformation, who when you, if you let her be by herself, she'll constantly turn her head all day. But if you have her fixate straight ahead, you'll see the reversal of the nystagmus. So here she is turned to the side, so she has no nystagmus. But if you have her look straight ahead, she's got a right beating nystagmus now. Typically it'll slow down, and when it stops, before it goes in the other direction, you typically get one or two downbeats as well. And you can see if you don't watch her for a while, you just say she's got right beating nystagmus. A couple of downbeats there, I think. And now we're beating to the left. You actually see the eyes sort of trying to deviate a little to the right before it beats to the left. This just goes on all day, every day. So that's periodic alternating nystagmus. Downbeat nystagmus refers to a rapid nystagmus downward, right? It's downbeating in primary position, but it may not even be seen in primary. It's typically worst in lateral gaze just below the horizontal. And it's due often to a cervical medullary junction lesion or a lesion in the vestibulocerebellum. So either Arnold Chiari or a tumor in that area or degenerative cerebellar disease like olivopontocerebellar degeneration. But it's also seen with various toxicities, all listed here. vitamin deficiencies, magnesium, thiamine, B12. It's seen with paraneoplastic disease, sometimes congenital, and of course idiopathic, right? So 40% at least we don't find a cause. And recently we've seen a couple of cases with the anti-GAD antibody, which is the typical antibody seen in the so-called stiff person syndrome, which is a neurologic disease, but it can cause downbeat nystagmus as well. And an anti-GAD can be idiopathic or it could be associated with a tumor and be paraneoplastic. So here's a case with an Arnold Chiari who's got subtle downbeat nystagmus, a patient of mine. In primary position, there's very little, but in lateral gaze, in either direction, you'll see downbeat nystagmus. So you see it there. These patients frequently have oscillopsia because when they look down to walk, when they look down to read, their eyes shake. A little more subtle in left gaze. Upbeat nystagmus is less localizing, but if it's worse in down gaze, it's likely a lesion in the medulla. Okay? It could be at the pontomedullary junction, it could be at the ponto midbrain junction, mesencephalic, or it could be in the cerebellar system. But if worse in down gaze, it's in the medulla, and various lesions will cause it. So here's a case post-traumatic with a lesion in the medulla who's got upbeat nystagmus, worse in up gaze. Now, we mentioned that torsional nystagmus is often seen with peripheral, but that's horizontal plus torsional. A pure torsional nystagmus is central, most often a lesion in the medulla. And it may be seen with one of the common forms of skew deviation, where one eye is higher than the other, called the ocular tilt reaction. Okay? So you might see the skew deviation and a nystagmus. So this is pure torsional. So the eye's not beating up or to the side, it's just rotating. And it's conjugate, we're just showing one eye. So those are the jerk forms of nystagmus. We'll go over some of the pendular forms, including it's horizontal or vertical, it could be oblique, circular, or elliptical. It's often asymmetric, dissociated. MS is the most common cause of acquired pendular nystagmus in adults. It can be seen with visual loss, certain toxicities, stroke, or degenerative disease. So here's a 25-year-old man, has a history of a hypercoagulable state that's familial. He gets a brainstem infarct with double vision, and 10 months later, during rehabilitation, develops oscillopsia. And he comes in, and this is what he has. So you see a combination of horizontal and vertical. You see that it's different in both eyes. It's actually converging and diverging, right? Anyone know what this is? Is it a new stroke? 10 months after his old stroke? So he has oculopalatal tremor or oculopalatal myoclonus, which is a rhythmic 1 to 3 per second movement of the palate, the eye, the face, and the larynx, which typically occurs around 10 months after a brainstem infarction, or an infarct involving molar raised triangle. So molar raised triangle includes the inferior olive, the dentate nucleus and of the cerebellum, and the red nucleus. And usually the defects in the central tegmental tract in the brainstem. And typically, acutely, the stroke includes a 1.5 syndrome, so an INO plus a conjugate gaze palsy. And 10 months later, they develop oscillopsia and a pendular nystagmus, and pathologically there's degeneration of the inferior olive that's hypertrophic. This is a one movement disorder that persists in sleep. And so when you see something like this in the eyes, you should look at the palate, and it'll go at the same rate. You see it elevating at the same rate. And if you look pathologically, there's hypertrophy of the inferior olive, and sometimes you see it on the MRI. And sometimes you see this on MRI, and they'll call it an acute infarct, but it's really just nothing new in terms of the vascular disease. It's subsequent to the stroke. The reason to distinguish this is that it may respond to certain medications that other nystagmus would not. Oculomasticatory myarrhythmia, you'll see 0 to 1 times in your life. It's a rhythmic 1 per second pendular convergence and divergence nystagmus, which is pathognomonic of CNS Whipple's disease. And these patients also have a supranuclear gaze disorder. So it's called oculomasticatory because it's usually the eyes and the jaw. So here's a patient from Novel, from Shirley Ray's collection. And you see that he's got convergence and divergence 1 per second. And the jaw's going as well. So you see this? This is pathognomonic of CNS Whipple's disease. Seesaw nystagmus looks like a seesaw. One goes up, one goes down. It's elevation and intorsion of one eye, depression and extorsion of the other eye. If congenital, it could be the reverse. And it's seen with patients, particularly with chiasmal type lesions, paracellular lesions. And that's pendular. In the midbrain, you can get one like this that's a rapid, but usually it's a slow pendular nystagmus. So here's a 33-year-old man this is 1 day postoperative after a resection of pituitary adenoma, which was large. He has diplopia, he has oscillopsia, and he was seen at Penn, where he was operated, and he's got this seesaw nystagmus. One going up, one going down. A sign of chiasmal disease. How often do we see this in chiasmal disease? Not 2, right? I mean, we see a ton of chiasmal patients. I've seen maybe about 3 in my whole career. So it's chiasmal, usually with a bitemporal hemianopsia, but if it's in the midbrain, it could be a rapid called hemiseesaw nystagmus. Okay. We will see one final eye movement, and that's superior oblique myokymia. So this is a monocular cyclovertical oscillation. It's not rhythmic. It doesn't have, you can't beat to it like you can the nystagmus. And they typically present, and you make this diagnosis by history. They come in and they have a unilateral oscillopsia or they have diplopia that lasts for short periods of time and occurs many, many times. And to bring it out, you put them in the slit lamp and you just look at them, and you might see it. You might have them look in the direction of the superior oblique, so down contralateral, and have them hold that for a while. It might induce it. But even if you don't see it, this history is pretty typical for superior oblique myokymia. It's idiopathic, but rarely there have been tumor in the midbrain that have been found in these patients, so you do have to scan them. So it's a unilateral phenomenon, and you see it's the superior oblique intorting, but it's not rhythmic. It's sort of like a jerking of it, like a string pulling it. And so that's superior oblique myokymia. So the types of nystagmus that are localizing include periodic alternating or downbeat to the cervical medullary junction or cerebellar, Convergence retraction we'll talk about when we do supranuclear, and that's the dorsal midbrain. Rebound is the cerebellum. Oculopalatal tremor or myoclonus is in the molar raised triangle, the olivodentatorubral pathway. Seesaw is in the chiasm or the midbrain, if it's jerk. Bruns is a CP angle. And when we talk about supranuclear, we'll also talk about opsoclonus and flutter, which is a lesion in the omnipotence neurons. And at another time, we could talk about treatments of this nystagmus, which is suboptimal, but some medications do work for selected people. So I thank you for your attention. Glad to take any questions. Okay, thanks. Hi.